Hi, I'm David Liew for Room Now from Copenhagen, obviously from my Copenhagen apartment, not the centre, because I've been kicked out of there, because EULAR 2022 has ended, and there's been a lot of talk about EULAR 2023 in Milan. So what were the highlights for me on the last day? Well, we'll go through a few more of those in a moment, but I wanted to talk a little bit about one session this morning, which had a number of big hitters in it. Ron von Vollenhoven, Philip van der Bosch, as well as Robert Landaway, this morning talking about whether essentially we can achieve, well, we talk about drug-free remission, early drug-free remission, but essentially we're trying to get rid of rheumatoid arthritis, whether we can try and make some sort of intervention that can prevent rheumatoid arthritis ever happening or to try and interrupt that process. Now, so I'd recommend going to listen to that session. It's entertaining, all three speakers there, going through RA, spondyloarthritis, peripheral spondyloarthritis, really kind of dragging it out. But I think there are a few nice bits of data that have come about at this meeting that really play into this idea that, you know, we haven't got our head around the kind of oncology idea of maybe this more intensive induction at the beginning to try and bend that immunologic course for the future. That's something they do in oncology all the time. That's something we do in other rheumatic diseases where we have an induction phase and then a maintenance phase. But that's not necessarily something that we do in rheumatoid arthritis. Maybe it's a legacy of what we have done in the past when it's a slow step up pyramid type approach and that we were more conservative, maybe because the data as it stands hasn't always supported it when we tried different therapies. Two abstracts. The first one was actually from the first day, this abstract OP0531, first day, second day. And it was actually the ARIA data that we saw at ACR, but with a little bit more detail that was alluded to there. ARIA was a 6-month a study where they gave 6 months of abatacept in clinically suspect arthralgias. So patients, in this case, who were ACPA positive, rather MRI findings, and had arthralgias, but no synovitis, and gave them 6 months of abatacept, and then left them for 12 months, and then saw what happened. And we saw the 6-month data at ACR, which there was a nice big gap there of 30%. If I remember, I think it was 92% of patients on abatacept didn't proceed to rheumatoid arthritis versus 60% to inflammatory arthritis versus 65% in the placebo group. And you might say, well, David, that's just treating early rheumatoid arthritis. You gave them 6 months of abatacept and a whole lot of them didn't develop RA. What's the big deal? Well, what they did was after that 12 months of not giving any therapy at all, and then what happened? Now, it was alluded to at ACR that they'd analyzed the data a few days beforehand and that it looked like there was a benefit. And certainly that's what we actually saw this time around. So actually, this time we saw the 18-month data, which showed 65% of patients who had abatacept previously didn't get inflammatory arthritis versus, I think it was 37% in the placebo group. Now, the gaps will narrow at different points. I think there's a lot to wash out there. And still then, I think we've got to try and figure out how we pick the winners. There was a bit of talk about whole genome sequencing and earlier in the meeting from work from Karolinska. And I think we've still got a long way to go to figure that out. But I did want to mention that I think even then, abatacept expensive. We've got to try and figure out how to best use it. Methotrexate, less expensive. Can we do other things with it? Well, so actually at the beginning of the conference, OP0070 was data from the Dutch, looking at a similar type of population, but with ongoing methotrexate treatment. In other words, is it worthwhile actually treating those patients who have those clinically suspect arthralgias? Now, it delayed the progression to full-blown rheumatoid arthritis. You know, that doesn't necessarily surprise. But what was interesting, really, was that there was improvements in function, improvements in presenteeism. Now, the paradigm has always been that we don't treat unless there's synovitis there. But maybe we can start to think about what very early rheumatoid arthritis looks like. Do we need synovitis to be able to give methotrexate? I ran a survey on Twitter, had about 180 respondents, and I think it was 72% were happy. In the case that which we presented, was they gave methotrexate. A whole lot of others gave other therapies, and only 3% didn't treat at all. So I think that maybe that's something we're already doing anyway, even if we're afraid to say it out loud. So for all the coverage from the meeting, and we've got a lot of coverage on RheumNow, head on down to the website, check us out on Twitter.